I'm Andrew Sharpe. I'm an advanced podiatrist working mainly in the area of the diabetic foot ulcer, but it's generally all foot ulcers. We don't limit ourselves to just the diabetic foot. I work over at the University of Huddersfield as well, 1 day a week at the moment as a lecturer practitioner as well. So what I'd like to talk to you guys about then is about the technology that we see in practice. And I'm not claiming to be the kind of the guru in knowing all about the technology. This has been very much from my experience of technologies that are involved in the diabetic foot in assessment and management, and it's looking at that type of element. So, as I mentioned, I'm a podiatrist working in Blackpool, and this is the Atlas of Variation for diabetes foot amputations, and it came out in 2012. And on the back of this, a lot of kind of investment and root cause analysis type incidents went on to find out why some services perform better than others. And it did account for all the kind of socio-economic factors that are associated with it. So if you're looking for I'm sure you're all probably looking for your own trust, but I'm going to point out where we are. Now, unfortunately, we are one of the worst in the country for amputations. In 2012, I wasn't working in Blackpool, so that's possibly the reason why. But what we've done is, interestingly, if you look down in the southwest of the country, so living in Cornwall is quite a significant issue if you're diabetic and your risk of amputation. But they've done some fantastic work in bringing down their amputation rates. And we're learning, the rest of the country, Blackpool in particular, we're learning from all these other trusts and how they've gone about doing it. So what we've had is a pot of cash invested from NHS England to try and improve our outcomes. And part of that element has been to look at the technologies involved, so that's why I'm talking to you a little bit about technologies as well. So what can we do to improve our diabetes foot care? It's interesting, we were having a chat about this last night in the bar, putting the world to rights. If you notice, quite a lot of the highest amputation rates, aside from a little bit kind of in the north and in the west, they're very much in seaside towns, and you see that this tends to be the picture. So you see it in Scarborough, they have a lot of issues with diabetic foot ulcer management. And one of the interesting topics that came up that I didn't realise about is that Blackpool actually, when the seaside industry dipped a little bit and you had all these accommodations, all these B&Bs with rooms available, is they used it as kind of council housing homes, and people came in from different areas, and it increased the kind of the issues that get associated with poor socioeconomic problems. So I'm going to cover a bit about diabetic foot ulcers, assessment, diagnosis, and standards of care, and then talk about the current technologies in assessment, measurement, and treatment. So we see with the diabetic foot that our figures are 972 million to 1.13 billion, which is equating to 2.66 to 3.9 million pounds per day being spent in this country on diabetic foot management. 2/3 of it, so the vast majority of it, is being spent in primary care, community care, and the outpatient setting. So it's not just the associated cost of being in hospital, a lot of it's spent in the community setting. In the UK, any given week, so as we're talking now this week, we've got 60 to 75,000 people in England. 2 to 2.5% of our diabetic population have an active foot ulcer as we stood talking. So I did some quick, crude calculations for Blackpool. We're looking around about 396 to 495 ulcers a week that we're managing. They're not all coming into podiatry, I can tell you that much. If I had done this presentation just over 12 months ago, we'd have talked about 7,000 amputations happening a year. We're now up to 8,500 amputations per year in the UK, which is a staggering 160 amputations a week, or 23 amputations a day. So as we've been here today, 23 amputations have occurred. We are seeing a decrease in major amputations, which is great, but we are seeing an increase in the minor amputations. Then the work that Julian Guest has done to look at costs of diabetic foot ulcers, we see that the actual cost of a diabetic foot ulcer per year is around about 7,800, and we can massively reduce that if we heal it up within the 12 months. So £2,140 versus £8,800 if they remain unhealed. and around about £16,900 per amputated wound. There used to be an old school of thought that because you're spending this money, you chop a little bit, why don't we just go straight into the major amputation? But thankfully that's a train of thought that's changing. So what else we do know is the health economics of everything is going up. So by 2020, we expect to see a rise of about 39% on wound care. So we need to see about a 1% increase in our healing rates just to stay at the level we're at, which is a staggering amount as we look at the stats there. It's about a 3% increase in healing rates to actually reduce the amount of money we're spending. So what do we do about assessment and diagnosis of the diabetic foot? So NICE has 8 key elements. First bit is we look at the nerves, we look at callus, which is a precursor often to ulceration, to see if they've any deformity, and deformity with nerve damage can be a big issue. And then there's a condition known as Charcot-arthropathy, which is commonly seen in diabetes and comes because of neuropathy. We see limb ischemia and gangrene is what we need to look out for as well. And ulceration, infection, and gangrene, and I'll explain why gangrene's there twice in a second. So ulceration and infection or inflammation being an issue as well. So essentially we talk about 3 key areas within the diabetic foot in terms of getting our foot ulcers healed. It's an issue of pressure, so it's walking pressures predominantly in the diabetic foot, and it's with or without sensation loss. We see issues with pressure damage in terms of when a patient's also ill, that comes into play with it as well. We see arterial disease problems, whether it's localized, so the tissue death for pressure causes a localized area necrosis, or whether it's a full-on systemic problem of arterial disease. We see diabetic foot ulcers are often a precursor to arterial disease, and arterial disease life expectancy of 5 years is around about 60% mortality. So about 60% of our patients with arterial disease will be dead in 5 years. So it's really important we get these early diagnosis and assessment right. Infection of the soft tissue and the bone, and I was having a chat with Andrew before around infection and the work he's done in the past, and talk about some of the technologies that are potentially coming out with that. So this then leads into the kind of the standards of care. So we look at pressure, we think about pressure, we need to offload. We're looking at controlling our foot infection, control of ischemia, wound debridement, and then wound dressings. So the 5 key elements there is how I've kind of tried to look at the technologies that are out there and what's available. So if we start off with the offloading, NICE standards, NICE gold standard, the gold standard for offloading in the diabetic foot is the total contact cast. But we only see around about 18 to 20% of patients who have a diabetic foot ulcer are actually in a total contact cast. So we've got a large number of diabetic foot ulcers without appropriate offloading being used. If we look at the actual evidence, we find that removable walker boots are suitable. If we make them irremovable, they're just as good as a total contact cast. It's the element of a patient taking them off that becomes the problem. So the type of technologies we've used in practice is, you may remember when David Beckham broke his metatarsal, he became kind of the poster boy for the air cast boot. So what the air cast boot does is it adds air into the system that then encases the limb and keeps it still and helps offload it. What we're seeing now is new technologies looking at taking air out of the system. So it's called the diabetic vacoped. So we suck air out of it and we conform then with loads of mini microbeads within the liner element. We've got some microbead technology in there that will therefore conform, and then the casted boot on the outside that will help with the offloading and redistribution of pressure. It's easy to apply. We can, and from a cost comparison point of view, so with a total contact cast, the casting tape is relatively cheap. It becomes expensive because you usually require 2 clinicians to apply, and you do sequential casting weekly, and it can sometimes be twice weekly. So if you're having to take that off and reapply, you can be talking around about half an hour to an hour, depending how skilled your individuals are to apply the total contact cast. and it can be quite labour intensive and time intensive, and that's where a lot of the cost is associated, versus one boot that you can keep reapplying. And we can actually make these irremovable, so we can put pieces of casting tape around it so patients can't take it off. If you've seen the stuff that Amazon and iPhones and things deliver with the tape, so it's like tamper tape to see if the patients have taken it off themselves. So we can do things to removable walkers to make them irremovable and to make them as effective then as total contact casting. But our evidence base still sits with total contact casting, but we do know we've not got enough patients in them. The other type of technologies that's out there, you may have seen, is one called Pulse Flow DF, which stands for Diabetic Foot. What I really like about this technology is that it's got a skin receptor on the device, so you can see how long it's been worn for. So patients almost have a lie detector built in. The issue we've found with this in practice is because it's quite a rigid foot shape element, we've had difficulty in getting our diabetic patients into it. So they've got to be the right kind of ankle bend and leg shape to be able to go into the boot, and it does need charging at night time as well. So I personally have had a few attempts and found it quite difficult to fit with patients because the diabetic foot is an awkward joint around the ankle, and that's part of the issue of why they ulcerate. But there is some ongoing research for this to compare its effectiveness against removable walkers, and it does have a venous return element of a compression technology that squeezes the arch of the foot and helps the blood flow back up out of the foot. So the technology of infection assessment, and often the debate around that critical colonization is kind of a forgotten, or not a forgotten term, it's not a very well accepted terminology because it's how do you measure critical colonization. It's very subjective. Microbiologists don't like it, but it can help with our early diagnosis and knowing when to use our appropriate antimicrobial stewardship. So there are technologies out there. Moleculite is one. It's been quite interesting to see. I've had a little bit of an experience with this to see about the antimicrobial decision and help with the debridement decision. The difficulty is, to my mind at the moment, is understanding the cost versus the benefit. So that's where I think it sits at the moment, and we are having a look at seeing where we can make savings and what we can help improve. But just to give you an idea of how it might work is you see the ulceration on the left. This is it under fluorescence as well then. So we can see that red fluorescence, this element here is all bacteria of 10 to the power of 4 million. So we know we know anyway that we've got a dirty ulceration, necrotic tissue in there that needs cleaning and debriding. But what's been quite interesting is it kind of has delineated the cellulitis. Now, I don't know whether this is part of its technology or it's just because we're seeing a colour difference anyway, that it shows it up. And it has helped us see that by using the antimicrobial with effective debridement, and this patient was on antibiotics as well, that we're seeing this improving its outcome. Like I say, we need to look more into it to see how well it's going to be in helping us in this infection debate. So from a ischemia point of view, if we look at arterial assessment, we're using handheld Doppler devices to listen to sound waves, but the question that you often get, or you often see, is the subjective element of, do you hear what I'm hearing? Am I hearing a biphasic pulse, or am I hearing a monophasic pulse? And that can be a big difference in kind of helping you with your assessment, especially in the non-ulcerated foot. If we're talking ulcerated foot and we're thinking there's an issue with ischemia, this forms part of our decision, and it's not our be-all and end-all, but there's an important role that can be played in the early assessment of peripheral arterial disease. So there's technologies out there now that look at visualizing the waveform. So companies like Huntley have brought out the DMX to look at actually giving us a visual waveform to have in clinic to use there and then. It seems to support the clinical assessment. It helps in that difficult to locate vascular signals. You do sometimes find the waveform is in reverse. Once or twice has happened for myself, but it's supporting your clinical decision making. From a wound assessment point of view, there's lots of technologies now coming around, because we all have smartphones, we all have tablet devices, and tablet devices are becoming the norm of using in terms of clinical day-to-day practice. So there are wound assessment apps coming out, industry are getting involved in this, and it's creating an algorithm in the background that kind of, as you input your data, it will make a suggestion on your dressing choice, which can be quite, it doesn't necessarily mean you have to use that dressing, you can override the technology, but what it does for you is at the point of data collection and the point of use, you're actually collecting a lot of data. So you're finding out what type of ulcerations you've got, how your ulcers are progressing healing-wise. You can link it in with photos and have a back catalogue of the photos to see how well the wound's doing. So I think these are going to be a big kind of support once we get past that barrier of the governance element of where the data is kept, etc. And it will help. So the application idea I've worked with Virgin Care, and what they've looked at is to look at having a remote specialist, so having just a couple of tissue viability nurses across their entire footprint of service, and they could use this technology to feed the information to the specialist, who doesn't have to necessarily be on site, and then you can do teleconferencing to discuss treatment pathways. How well that'll work, and I'm sure that's kind of a contentious area because you're reducing the number of nurses, but it might help improve knowledge and understanding down the way. Another key one really is to look at 3D photography. So depth has always been a difficult one to manage and measure, and as we see new technologies emerge with 3D photography, it helps with the overall area of the wound and the volume of the wound and how well it's healing. And we can see a reduction in volume when we don't necessarily see a reduction in wound edge and area, wound edge and length. So the final part then is to look at wound dressings and evidence-based wound care. And it's quite interesting to see that we've often talked about needing a randomised controlled trial within wound care companies. It's now being done. So we've seen the first randomised controlled trial in the Diabetic Foot with Ergostart comparing itself to an inert version of a mesh. Double-blind randomised controlled trial, Explorer trial, published in the Lancet. And it's the first double-blind randomised controlled trial we've seen in diabetic foot ulcer management. And that's demonstrated a reduction in, an increase in the, what would it be? A reduction in the healing time, not an increase. Now, what I would love, and I've been very lucky in getting hold of this, is a future technology that I've been able to use, and it gives us temperature difference, gives us circulatory assessments, nerve assessment, it assists in the clinical decision making. It's relatively cheap and freely available, and it assists dressing application and debridement. And it's one of the best pieces of kit that I think we've been able to be invested in. It's about using our brains, using our eyes, and using our hands, and having a good feel. So if we look at pulse palpation, that tells us a hell of a lot about ischemia. We don't need to spend... The technologies that are out there are supporting us, and they're helping us with this decision process and this change in practice. But it's also remembering the basics and going back to basics. Ipswich did a touch-the-toes test for in-hospital management, so you don't even need a relatively cheap monofilament at £15. You can use your finger to test for neuropathy assessment. And we can feel for temperature gradient differences as well with our hand. So it's a fantastic piece of kit is the hand. So diabetic is costly and will continue potentially to get more costly if we don't start to reduce it. So what we need to look at is reducing clinical contacts where we can, empower patients for self-care, try and improve our healing times, look at evidence-based practice, and keep testing these technologies to see how else they help. Technologies will support and aid our clinical decision-making, but we already have the true technology in our hands. Thank you very much.